Bismillahirrahmanirrahim. My topic of is tracheostomy in severe head injury. I am Dr. Fazal Ghani, consultant neurosurgeon, KTH, Khyber Teaching Hospital, Peshwar. The mechanism of secondary brain injury that is well known to almost all of us, that hypoxia, hypotension, increased intracranial pressure, hypercarbia or acidosis. These are the main causes which leads to secondary brain injury, mostly in severe head injury patients. This is the cranial compartment, which consists of the brain parenchyma, blood, and the CSF. And the two things that can be that give some compensation for the intracranial pressure, that is the CSF and the venous blood that drain out of the cranial cavity and lead to the decrease in the intracranial pressure. As we already we discussed that the raised intracranial pressure in mild to moderate in head injury, mostly the intracranial pressure is up to 20 mm of Hg, and in severe head injury patient it reaches to almost 30 mm of Hg. And we can see that from that compensatory mechanism, from point 1 to 2 and to third point, we can see that the intracranial pressure is not raising that much due to that compensatory mechanism of the CSF and the venous blood that drain out of the cranial cavity. But after the third point, there is a sudden vertical raise of the intracranial pressure, and that's because of loss of the that mechanism. And in my topic, that is on the tracheostomy in severe head injury patient, this point is very important, because at this point, if a slight increase occur during shifting of the patient or during performing tracheostomy, that will lead to a sudden vertical rise of the ICP and can lead to deterioration. The objective of my study is to determine the risk of secondary brain injury in early and late tracheostomy in severe head injured patients. This is the overview of my research article. In introduction, the tracheostomy is an effective procedure in patient with severe brain injury for improving patient comfort, reducing need for sedation, lowering airway resistance, allowing for easier airway care, and weaning from ventilator. These are the common indication for which we perform the tracheostomy. The appropriate timing for endotracheal intubation in severe brain injury is well defined, that all patients with GCS less than 8 or with extensive facial or oropharyngeal trauma should have endotracheal intubation in the emergency department and must be mechanically ventilated. However, there is no data that give adequate timing as to when convert an ETT tube to a tracheostomy tube. The indication, timing, and patient selection for tracheostomy is controversial among different centers. Indication in severe brain injured patients consist of airway obstruction due to decreased consciousness, difficult to wean from mechanical ventilation, and excessive secretion. The sample size in my study, 180 patients, early tracheostomy was performed in 95 patients and late tracheostomy in 85 patients. This was carried out in Neurosurgery Department, Lady Reading Hospital, Peshawar. The inclusion criteria was those patients were included who had spontaneous breathing on mechanical ventilator and they were vitally stable. And the exclusion criteria was there was no spontaneous breathing on mechanical ventilation, or they were having some other problem, vitally unstable. These are the results. You can see that total number of patients are 180. And the early tracheostomy was performed in 95 patients and late tracheostomy in 85 patients. And the patient dropped GCS in after early tracheostomy was 37% and the late tracheostomy was 11%. And the same way, the other data is also showing that the late tracheostomy carries better result, less chance of secondary brain injury than the early tracheostomy group. The conclusion, there is risk of secondary brain injury during tracheostomy, especially performed within 7 days of severe head injury. So the conclusion also include that the tracheostomy should be performed after 7 days of head injury. The patient must be hemodynamically stable. The arterial blood gases should be in normal range, and there should be spontaneous breathing on mechanical ventilation. Patient should have no associated, or there should be care, a lot of care should be taken in tracheostomy in patient with some associated chest or lung injuries, or patient having comorbidities of asthma or other COPDs, or the patient develop ARDS during mechanical ventilation, then these patients should not be taken for tracheostomy. Thank you.
Yeah, sure. Just the comments that any patient on mechanical ventilation lying in the ICU should not be shifted to the OT for performing the tracheostomy. It should be done on the bedside, and you just need a few instruments and one bipolar diathermy. You can perform on the bedside. So my routine is that from last many years, I have not shifted any patient to OT for performing tracheostomy. I just do on the bedside. In the ICU, you have multiple people who can support you by giving the sedation and etc. And you don't need any shifting to the OT.
Sir, even if you are performing on bedside the tracheostomy, still during this procedure there is risk of hypoventilation, hypoxia, hypercarbia, and acidosis, and that can cause even at that time, if the patient is having 30 mm of Hg, the ICP, then there may be a sudden rise of the ICP and the patient can deteriorate. That's why my study is showing the same results, that after tracheostomy, the patient deteriorated more in the early group as compared to the late group. Because in the early group, there is poor regulation of the auto-regulation of the cerebral blood flow, and all the things are more critical in the early group. So if the patient is kept on the mechanical ventilation with endotracheal tube in the early group, that gives better result to go for the tracheostomy later on. And in the other cases of chest trauma and having some underlying lung comorbidities, these patients are at more risk of developing hypoxia and hypercarbia and acidosis that can lead to sudden vertical raise.
Surely, I agree with the late tracheostomy, but it should be done preferably in the ICU setting.
Yes, sir. Yes.
So just a comment which I made earlier also, for low resource settings, I think tracheostomy for a head injury patient is the best thing to do. When I came back in 1990, the ventilators were considered as death traps because nobody was able to really monitor the patients, or there was no intensivist to look after that. And we found that doing a tracheostomy, no data of course, but doing a tracheostomy early really saved many lives, and I think also reduced the morbidity. So converting intubation into tracheostomy, yes, of course, but I've seen patients who were intubated and left just like that. So I mean, increasing their dead space. So best to do a tracheostomy for people who do not have a good mechanical ventilation facility available to them.
You long ago. It was published in Journal of Neurosurgery. tracheostomy benefit. So we had the data that supported that the early tracheostomy is beneficial for the patient. It decreases the cost, it reduces the ICU stay and everything, and patient's rehabilitation. All in all, early tracheostomy was much better for the patient rather than the late tracheostomy. And this article was published in Journal of Neurosurgery.
Yes, sir. There is that article which that is the benefit of early tracheostomy, that we can shift the patient earlier and easy weaning from the ventilator. But in this group, the risk of secondary injury is more as compared to the late group. That is there in many, and I have read that article what the sir is discussing. Okay, sir. Thank you.
I have a question. I have a question with the Fazal Ghani. I have a question that you are doing late tracheostomies. How often you have to change an endotracheal tube at midnights before you change your endotracheal to the tracheostomy late? It often blocks when you are.
Yes, you are asking that. You are asking about that the tracheostomy to change the endotracheal tube. Endotracheal tube, if blocks, then you can change to another endotracheal tube at that time. Yes, you can call the anesthetist. You can do it by yourself. If you are neurocritically trained, you can change the tube. And you can change it with the guide wire, that if you put a guide wire and you remove that tube and you put another for that. Yes, you are right that even that changing the tube can lead to that problem. I'm talking about the most frequent cases that we go for the tracheostomy, and the tracheostomy carries these risks. No, lung trauma, I didn't discuss the lung trauma during intubation or during tracheostomy. If the patient is already having some lung trauma, because mechanical ventilation needs high pressures or more oxygen to such patients. And if they have already chest trauma during head injury, these patients are at more risk of secondary injury during these procedures.
With the permission of the chairman of the session, I need to ask a question from Dr. Fazal Ghani. Dr. Fazal Ghani, it was a very interesting research which you're going on in your department, but I think there's a lot of work to be done on it. The experience which we are having in our department, and it's a proven fact that the endotracheal tube is itself, endotracheal tube itself increases the ICP, and it increases the chances of secondary brain injury. So ETT increases the chances of secondary brain injury. That's why from a very long time, as sir mentioned, that in our setups, and we are using the tracheostomy since long. And once you have done the tracheostomy, it's a procedure of just 5 to 10 minutes. It doesn't take any more time. So the chances of secondary brain injury, which you are mentioning, they are just 5 to 10 minutes, which you have to cover the patient to avoid the secondary brain injury. But if you do not put a tracheostomy and you go on with the endotracheal tube, it's a proven fact internationally that endotracheal tube increases the ICP and it increases the chances of secondary brain injury. Thank you so much.
Sir, with mechanical ventilation, if your patient is on mechanical ventilation and the patient is having ETT in its place, you can control the pressures and other parameters more better than with tracheostomy tube. Because the tracheostomy tube, if the patient needs more oxygen, more pressure, like more PEEP, then there is risk of leakage from the sides.
Then will you please explain that what is the importance of dead space? If you decrease the dead space, it improves the oxygenation or decreases the oxygenation? Well, what is the basic concept of tracheostomy? The more important concept is that you decrease the dead space. Once you are having a tracheostomy tube, you have decreased the dead space and it increases the oxygenation. So I don't know. Yes, I initially mentioned that there's a lot of work to be done on it because it's really a new concept for everyone from us. I don't think that everyone here have ever heard about this new concept, but that's great. I think you need to work more and we need to have many cases to. Thank you so much.
And ask him during the lunchtime. We're going to have lunch because of the shortage of time, because the next section starts at 1:45. If you have any burning questions, you can meet Dr. Fazal Ghani or any other speakers during the lunchtime. I'm sure they would be there. Let me thank all the speakers for their excellent presentation. Thank you very much. And with this, we conclude this session. Thank you.